Yes, السلام عليكم ورحمة الله. أسعد الله مساءكم أجمعين. Uh, you see my
Can we?
slides here?
I think he
Yeah.
can hear
ما
us.
نسمعك
Yes.
عثمان، انت على الميوت. شوف كده، حاول كده.
Sure.
ايوه، ناو نسمعك.
It is on.
علي
Yes.
صوتك بس.
طيب أبشر.
بعدين يعني البدله هذه يعني ماخذه حته منك ما شاء الله.
الله يحفظك. مساء الخير أجمعين. أولا would like to thank you all. الله يحفظكم. I would like to thank you all for having us in this meeting. It is a pleasure and honor to be in this meeting. Thank you for the Saudi Society for Cardiac Surgeon and the SASAS, and for the Heart Forum. Congratulations, Dr. Adil, for your persistent working in this, and congratulations. Would like to start my lecture, which is about the hybrid. It's very hard to follow Dr. Saleh or Dr. Ali. They spoke a lot about this one. I don't have any disclosure. So regarding the hybrid, I'm not sure how many of the audience they do have a hybrid car, electronic car. Anyone?
What's your question again? Sorry.
The electronic car, the hybrid
Electronic hybrid car. Yeah. How many from the audience has a hybrid? Nobody. نحن ما نحب الهايبريد، نحن بس لوسيد بس. يعني احيانا بعض يعني a lot of the government agencies. When I'm going anywhere في الرياض بسيارات الوزارة أو سيارات المجلس, they give me a hybrid. A lot of the government agencies, they have lucid, but not very common here in Riyadh.
So it might be common at some point. So let's learn it a little bit so we'll be ready at the end of the day. So whenever I see a CABG patient, I usually think and talk to myself about four important things: the short term, the long term, the conduit durability, and the evasiveness. Dr. Saleh went over the mid-cap and the other options, the hybrid revasc, which is the new thing coming into the market for all of us, which is combined both between the open procedure and stents. Minimal invasive surgery classified to 4 levels. Level 1, direct vision mini incision. Level 2 is video assisted. Level 3 is robotic. And level 4 is tele-robotic. The evolution of CABG started on pump, full sternotomy, then off pump with full sternotomy, and now off pump mid-cap, and now we are seeing the robotic hybrid. The first was described by Califiori and his team with integrated Lima to LAD and multivessel angioplasty for the other non-LAD lesions. Over the years, it has been described. This is the OR of how it looks like with the robotic assisted CABG. So what is the definition of the hybrid? The hybrid is a sternal sparing, off-pump, minimal invasive, hands-on left internal mammary, or even robotically sewn, Lima to LAD plus revasc for other with the PCI. The hybrid revasc was described, and there was a lot of studies upon that. 5 years of clinical outcome compared to the CABG itself. There is no major difference in the MACE between the hybrid and the multifissile disease and meta-analysis. The results reveal the hybrid coronary revasc is a safe and therapeutically effective alternative in the treatment of multifissile disease, and it is good in long and short term effectively. What's about the diabetic patient? This is a very hot topic in the hybrid surgeon. It is a unique approach toward multifissile disease, but it has to be discussed in the heart team and chosen very well for all the patients that they need hybrid approach. I know some majority of the surgeons, they don't like to see this, but this is the fact. The vein failure is at 1 year, it's around 10 to 30%, 50% occlusion at 10 years. From the data about the drug-eluting stent, the patency is 2 to 3 at 5 years, and restenosis at 10 to 15% at 10 years. I'm speaking here in non-LAD lesions. So what's the guidelines speak about? 2020, 2021 and the ACC AHA guideline for CABG recommend primary purpose for performing hybrid coronary is to decrease the morbidity rates for traditional CABG in a high-risk patient. The European Society Hybrid Coronary Vasc has a Class 2B recommendation for specific patient subset only at experienced centers. What's about the other guidelines? They have it as a 2B and 2A in 2A for isolated lesion, 2B in non-isolated lesion. What's about the Canadian guidelines? Hybrid coronary revasc typically performed with a minimal invasive incision with the Class 2A. So in the latest one, which is the review for the coronary hybrid revasc, there is excellent results for long-term effectiveness. So here we compare between both, either gas or electricity. Believe it or not, the projected safe from this procedure is around 43 millions, compared with the both minimal invasive, robotic, and extra. So we don't want to look like those people at the end that the math teacher, they protest against the calculator. None of us will do calculation without calculator. So what is the limiting factor for the robotic CABG? There is a lot of limiting factors. No hospital administration support sometimes, technology cost, low CABG volume, surgeons' interest as well. Sometimes in the OR, the anesthesia, they want to finish early, no dedicated team and the training. And believe me, you could overcome all of this. If there is a will, there will be a good outcome. So we'll see the common things, which is 67 years old male who is not known to have any diabetes or hypertension, presented from outside hospital with the chest pain. He was showed the CTO of the LAD and distal RCA. Here is his angiogram. You could see here it is almost like two-vessel disease, but with the CTO LAD, which could be done percutaneously in such cases. But we will see what we did for them. In our center, we examined this and we published on this one our first 78 patients, all patients with the coronary artery disease, at least 2 epicardial vessel disease. Exclusion criteria, we excluded most of those patients in the first cohort, which is 78 patients, but in the following, after the 78 patients, the only people that we excluded is the intramyocardial coronary artery disease. And some chest deformities. The contraindication is here, as I said, if there is a previous left chest surgery or pectus or severe LV dysfunction. Although all of those things, we, with time and with the help of the team, we overcome all of them except the intramyocardial LADs. This is how we do them. We classify them as stable ischemic heart disease and acute coronary disease. And for the STEMI, we do the PCI to the culprit. For the non-STEMI, if they are stable, we discuss. If unstable, then PCI to the culprit. And we rediscuss that one, and we do robotic limit LAD and complete revasc before the patient goes home. The 5 years outcome for all of the patients was 262 patients, 95% have clinical follow-up, 98% were free from angina, and 5 patients were admitted with acute coronary syndrome, revealed patent limit to LAD, and only to the diagonal and other vessels. Here is the numbers for the patients, and here is the results. The conversion rate is 3 patients over the cohorts. The hospital mortality, 2 patients, and 2 of them is end-stage renal disease with a lot of comorbidities. The length of the ICU, we try to make it less than 24 hours. Majority of them we extubate in the OR or after 4 hours from surgery. In conclusion, it is safe and it could be done and repeated in anywhere. We did the quality of life for all patients, which showed an excellent performance in all domains for the robotic versus the CABG patients. The obesity patients, for both patients in either BMI high or BMI low, both of them, they do the same. Also in the left main coronary lesions, we did this for majority of the patients, but we selected them carefully. And you could see their Euro score here is high in majority of them, and it was doable for majority of the patients. Here is the one of the patients that we see with the left main of 60%. And LAD. So we did the hybrid approach. We stent the PCA, stent the CERC to the other the CERC to the LEMA to LAD robotically, and then stent from the left main to the CERC. This is our results. There is no death in the page in our cohort, which is around 15 patients so far in the left main cohort. But of notice, they do have more AFib than others. So in conclusion, establishment of robotic hybrid program is feasible with the great potential. Robotic hybrid merge the long-term benefit of the LETA to the LAD and the PCI to non-LAD lesion, and there is a noticeable low rate of major adverse cardiac and cerebral event at 5 years. Thank you.